Yeah.
Thanks, Allison. Good morning. Thanks to AEI and PBGH for hosting this morning. I'm going to focus my comments on some of the innovation we've been doing around accountable care organizations and some direct contracting that Boeing's been doing with the provider community. And this is really born from frustration that I think a lot of employers feel about the high cost of healthcare. We spend about $2.5 billion a year. We have about 500,000 covered lives. So smaller than some organizations, different maybe than Walmart, though we do have some pockets where we do have a high concentration of employees, which does inform our strategy for these accountable care organizations. But it was a frustration with not only the line item of healthcare expense, but the year-over-year trend that we were experiencing. And I've been in this business a while, and it's kind of a sad state when we think 6 or 7 or 8% trend is decent, and we need to solve for that because it's not sustainable over the long term. So we had worked a lot of the demand side strategies, asking our employees to pick up more of the tab. We definitely believe in the consumerism effect of the HSAs, and we think that's a great strategy. But we wanted to take more of a step towards working more directly with the supply side of things and seeing if we could move ourselves into that space in a more meaningful way to help drive more accountability and value in what we were paying. And I echo Sally's comments about it's maybe not the line item that's as frustrating as just are we getting the quality that we want out of that line item expense for the company. So we moved into this space. Traditionally, employers contract with insurance companies or TPAs to handle their network management and network negotiation. We decided to go directly to the provider systems, and it wasn't really that we didn't feel the insurance companies were capable in this instance. It was we could go to the table with a clear understanding of Boeing's population. We understood fully that investments we made in our employees, this year will pay dividends 4 or 5 years from now because we have long tenured employees. So when we're talking about hospital systems taking risk, it was easy for them to understand, and we could have an easier conversation about risk than you can with an insurance company when they have fully insured risk, they have individual market risk, they have people coming and going. It's a much more complicated discussion. So that's why we went directly to put these contracts in place. We have 5 of them around the country that are live now. We have about 30% of our eligible population is enrolled in one. And maybe different than Medicare ACOs, people go through an annual enrollment process and actually elect to be in an ACO, so they know they're in a little bit of a different program. And essentially how it's set up, the contract really follows the AAA in healthcare. We aligned the contract on 3 principles: improving the member experience, improving quality, and improving the value that we get for that. So I'll touch on each one. From a quality perspective, we introduced about 15 NQF measures. We're certainly looking at a lot more markers than just that, but we wanted to not put 100 in the contract. So it's a wide spectrum of clinical outcomes, preventative care screenings, C-section rates, that kind of stuff that we measure and hold the systems accountable for. The member experience stuff is a little softer. Things like having a 1-800 triage number that a patient can call to help them navigate the system. We all know that's a very daunting task, especially for those that are seeing multiple doctors and hospitals. That's important to have triage help. So they do that. Dedicated websites, giving our employees access to their electronic medical record and communication with their physicians over email, stuff like that. A lot of that stuff was happening anyways, but we, I think, moved the needle a little bit on how quickly that was happening. And I think the real meat of the conversation was obviously around aligning the financial incentives with the systems. And until we do that, we're going to be stuck in the fee-for-system world where they're paid for volume and not paid for quality. So that part of the contract, the actuarial model is a little bit complicated underneath it, but at the surface, it's really pretty simple. We incentivize our employees to elect one of these ACOs. They go get their care in this integrated healthcare system. They get most of their care, 95+%, maybe more. And that will drive volume and revenue to that particular hospital system. Integrated hospital system, and in return for that, they're willing to guarantee and take risk and guarantee financial trend for us over time. And if they meet their financial targets and if they meet their quality targets, we'll share the savings back with the system. And the systems are, we have 5 of them. I think we'll see different levels of performance, but we very much feel like we'll be cutting a check to some of them for their performance, which is our goal in the end. We want to pay them back because that means they met their goals. And so that's what we are pushing for. So it's great to have a contract that aligns incentives, and then you ask the question, well, how are they going to get this done? Because they have a pretty daunting task. These are aggressive financial targets, and they got to figure out, the integrated system has to figure out how do they deliver care in a more efficient way. And I think, again, varies by systems, and I think they've done a decent job of kind of analyzing, well, how are we going to deliver care more efficiently? And I think you can look at it in different pockets. There's things like, spine surgery, for example. We're happy to pay for spine surgery if it's 100% necessary, but if physical therapy would do, we don't want to pay for that. And obviously that's a little bit of a conundrum for them because it's a revenue generator for them. But now that they're held accountable financially, they need to make sure that they're installing the right protocols and clinical pathways, that we go through all the right procedures before we do expensive surgeries like that. Prescription drug management's another one that's easy to see and understand how they can help manage that better. We wouldn't expect physicians to understand Boeing's formulary versus other companies' formularies, but I expect their information systems to understand that. And when they're prescribing drugs, they should be prescribing generics if that's clinically efficient. And we've seen a good uptick in generic prescribing rates, and we give them almost real-time prescription drug data as part of this arrangement so they can understand which of their physicians are outliers in their prescribing patterns. Investment in their information systems is pretty important now that we're directing employees to go get all their care within an integrated system. Well, they should be able to manage that patient better, but they need to make sure all the systems are talking and they have a shared care plan, and all the doctors that are interfacing with that patient are operating off the same integrated system. So that's a big thing. We've also talked with some systems, I think even their compensation structures that historically been rooted in volume-based compensation, they're making steps towards, let's introduce more quality compensation. I think that's an important piece here. It's a step in moving away from just fee-for-service medicine. So, and again, it varies by system, but those are some of the big things we're seeing them do pretty immediately to try to meet these financial challenges. In terms of results, we're very pleased with the quality improvement that we've seen. Our members really like it. We've done some focus groups, and they generally rate the ACO 8 or 9 out of 10. So the employees like the service they're getting. And I would say I'd leave you with a couple maybe specific examples that get us really excited. I think of course we want them to improve quality. Of course we want them to meet their financial targets. But we get really excited about what we're seeing some of them do in specific pockets. And I'll give you 2 examples. One is e-consult. And this is a big thing for our business from a productivity standpoint. Historically, someone goes to a primary care physician. If they're unsure, they send them to a specialist. That's another 4 hours away from the office or the production line, and another specialist hospital expense. Well, if that primary care physician can do an e-consult in a meaningful way with a specialist without having to send this employee back into the system, that's a huge win for us. That we may not even see that in our claims data, but the productiveness that brings to the company is hugely important to us. So cool things like that. The other thing we're excited about seeing is behavioral health. You take a place like Washington, Seattle, where we haven't historically had a lot of managed care. Behavioral health was just not talked about at the primary care level. The physicians weren't very good at addressing the physical needs, not very good at addressing the mental health needs. And the data is extremely clear, and everybody would know that depression is comorbid with every other condition and needs to be addressed at the primary care level. But there was no reimbursement mechanism for that, so I wouldn't blame the primary care physicians for not addressing that in a more meaningful way. So what we're seeing some of the systems do is figure out how to integrate behavioral health into their primary care clinics, because they know they are financially responsible for these folks over the long term. So they see the value in investing in that. And I think the reimbursement mechanism can follow and people get that sorted out, but we're excited to see bigger delivery system changes like that, like figuring out behavioral health. We've seen them begin to pilot more enterprise approaches where a psychiatrist is triaging folks, or even integrating a mental health specialist actually into the clinic so they can do a warm transfer. So it's stuff like that I think we're optimistic that this will enact some change by forcing accountability to them. And I guess I'd leave on that note of optimism. I also think this is a multi-stakeholder issue that the country is facing, and we need employers, policymakers, insurance companies, and the provider systems to all kind of come together to figure out a way forward. It's really not one entity is going to be able to solve for this. So I'll leave it with that. Thank you.